So my objectives are to describe evidence-based interventions to prevent medical adherence problems, evidence interventions to treat adherence problems, identify ways to deliver effective interventions via technology, web-based phone apps, that kind of thing. And then we're going to apply adherence theories to case studies. Definition of adherence. On the left is the one that's been used for a long time. On the right, the one that the World Health Organization uses. The difference between the two, because they both talk about the extent to which a person's behavior in terms of doing these things we ask them to do coincides with medical or health advice. The difference is the World Health Organization put in corresponds with agreed upon recommendations. So the idea being that patients and families, when they're presented with a diagnosis and a treatment plan, at least have initially agreed to try to follow that plan. So that's been the change in the two definitions. I think this is the World Health Organization is the one we should start using more often. So here's some medical adherence caveats. Providers need to be adherent themselves to recommended clinical care treatment guidelines and prescribed efficacious treatments. There's some evidence to suggest, for example, that children, African American children in particular with moderate to severe asthma, are not prescribed adequate treatment programs. They're not given, for example, an inhaled steroid. You can't expect people to be adherent to regimens that are not efficacious. Avoiding the blame and shame approach. I don't see this as often, although I have seen it in the past where the doctors blame the patient for not following their treatment and have not looked at their own behavior. I don't know if we need to do much about encouraging active role for patient and families in healthcare. They tend to speak up a lot more often now, and they've been on PubMed, and they come in with a list of questions and things, which I actually think is pretty good. And then to realize that sometimes people are non-adherent, and that may be rational. So if a child has arthritis, and they've been taking a non-steroidal anti-inflammatory, and they start having bowel movements with blood in it, and the parent stops the non-steroidal, that turns out to be a really rational decision. Or if they have severe pain and it turns out they have an ulcer. So there are times when people have made decisions about discontinuing their treatments that have even saved their lives. So when you look at non-adherence, it's not always an irrational act. Types of medication non-adherence that we see: people don't fill prescriptions, they delay filling them, they omit doses, they have drug holidays where they don't take drugs for several consecutive days. And that can be a problem, particularly if you're taking cardiac drugs and you go back on the dose that you had before the holiday, and that can result in some toxic effects. Toothbrush effect, we all know that before you go to the dentist, next Tuesday I'll be seeing my dentist, and Monday for sure. Lots of flossing, lots of brushing. Of course, I always do it anyway, but I'm going to really, really do it up big before I go see him. Then white coat adherence means that people tend to be more adherent before they go see their doctor and after they go see their doctor. And then people actually overdose or take extra medications. Now, these are really busy slides, but I just want to illustrate the extent of the problem with adherence in different areas. And if you look at this one, here is adherence to inhaled steroids as treatment of asthma. And you look at mean levels here, and a lot of these have been done by electronic monitoring, and they really are around the 50% mark, 45, 48, 69 in this study. You have to be careful. In some studies, they're reporting the mean, which is they're just simply looking at, calculating the mean across the sample. In other words, like ours, we calculated the mean, but we also looked at a cut point and said that anybody who had adherence levels below 80% were non-adherent. And that resulted in 65% of patients classified that way. Now you might ask, where did the 80% come from? The 80% came from initial studies with adults with hypertension, and it was shown that if they take 80% or more of their anti-hypertensive, they had systematic decreases in their blood pressure. That is an arbitrary figure. It's been applied in the literature. I've even been accused of inventing that criterion, which is not true. And we know that for diseases like HIV, that the adherence levels really need to be above 80%. So cancer, the interesting thing about cancer is there are very few studies that have been done. If you look at these dates, 79, 83, 92, and they all showed by urine assay or serum assay that a fairly good percent of the kids didn't take their prednisone, treatment of cancer. This Smith et al. Lansky study occurred at the University of Kansas way back then, and surprisingly, not much has been done since then. So if somebody has a desire to really do something in the area of adherence and pediatric cancer, that would be a really good contribution. The one that's come up in GI is the gluten-free diet. And there's a lot of discussion. I heard it on the TV this morning about whether gluten-free is good for a lot of us, not just people with celiac disease. But they've looked at these, and the interesting thing about this literature is they have all kinds of ways of measuring adherence. They have pediatric gastroenterologists classifying people. They have dietitians interviewing people. They have serum antibodies and clinical exams and nitric oxide levels and patient-parent interviews. But it's kind of 54, 29, 70%. It's all over the place, but generally it hovers around that 50% mark that you usually see with chronic illnesses. You'd expect that adherence to antiretroviral medications, treatment of HIV would be high, given the severe consequences of not adhering. And generally they are fairly high. You can see that by electronic monitoring in this one study here, it's about 81%. It dropped to about 79% 3 months later. If you ask caregivers about missing doses, they report in the 44, and patients too, in the 44, 40, 43, and as low as 16% in the last 3 days. So it depends on partly how you ask, what period of time you ask, but there's enough here to be concerned that patients are not taking that 95% that they should. Non-steroidal anti-inflammatories, most of the studies have been done by our group, and in this first study was by parent report, and you can see the parents reported fairly high levels of adherence. Pill counts, that's a low level of non-adherence. Pill count, very high level. But if you look at serum assays, and these were old salicylate drugs, but it was around 40%. Our own study looking at electronic monitoring, we found that there was partial or no adherence on 21% of 28 days. And if you use, again, the cut point of 80%, 48% of the patients were classified as non-adherent by electronic monitoring. Again, that's what most people find in the adult and pediatric literature. 50 to 55% of people don't take the medicines as they should. Post-transplantation is particularly a problem given the lack of organs we have available. But as you can see, non-adherence rates by pill count, 43%, electronic monitoring, 21%, again, looking at that less than 80%. So when you're looking at studies, make sure you know what the authors are reporting. You know, see, here they're saying mean 80%. So what they've done is they've looked at, they've calculated the mean for the whole sample. But if you're talking about this study here, what they were looking at is those people that dropped below 80%, and it turned out that 21% of them dropped below 80%. So, try to figure out what they're really talking about in some of these studies. So what are the consequences of non-adherence? It compromises the efficacy of effective treatments. Treatments don't work unless you do them, right? That kind of thing. Physicians unaware of non-adherence may order more invasive, risky, and costly procedures and prescribe more potent meds with greater side effects. There's poorer health outcomes, functional limitations, school absences, reduced quality of life. There's rejection of transplants because of non-adherence. In this one study, 71% of non-adherence patients lost a kidney transplant. Now, that's doubly tragic in that the person that got the transplant loses it, and then you got all these people on the waiting list who die, particularly with heart-lung transplants. So it's a big deal. Non-adherence has been associated with higher viral loads in HIV. Cost of non-adherence is about $100 billion a year. So how do you enhance adherence? These are the general strategies. educating people about their disease, treatments, and importance of adherence, organizational, delivering healthcare in a way that facilitates adherence, and behavioral, which is cognitive behavior change strategies to enhance adherence. The what of education is the disease, what causes it, the course, prognosis, treatments, what to do and why, negative side effects, and how to minimize those, and the importance of adherence. And often nurses, doctors, people, regular people in the clinic don't talk about the importance of adherence. They just talk about the issue. There's some good evidence that it helps improve adherence. And so education is an ongoing thing. So people, families would come in for the first time, for example, when their child has a serious illness, maybe cancer, and explain, here's what your child has, here's what we're going to do to treat it, here's the course, usually that it follows, and here's the prognosis. And then they came back the next week and they asked the same questions, and the doctors say, well, I already told them that. Well, okay, you did, but what's the emotion that people feel when they've first been diagnosed with a serious illness? They're pretty anxious. And when you're anxious, your memory kind of goes a little bit, right? You forget things. So they do need to be repeated. We need to be patient with families when they keep asking the same type of questions, and also have answers, written answers to these things that they can understand. So using effective verbal communication, avoiding the jargon, stressing instructions, repeating information, encouraging questions. It's interesting, the jargon part of that. There was a little girl in one of our studies that overheard her doctor saying that her knee was inflamed. She had arthritis. She thought, because she had read some article somewhere about spontaneous human combustion. You ever heard about that? I've never seen anybody burst into flames, but I worried about it as a kid. Did any of you ever read about it and think, oh God, I hope I don't burst into flames sometime? That's what she thought was going to happen to her knee, that inflamed mean it was going to burst into flames. So. And then one kid, I was talking about a tongue depressor, and he said, what makes them depressed? Tongue depressor, what makes them depressed? I'm going, what? Tongue depressor. Oh, I get it. Okay. There's a different word for depressed. We talked about pressing on your tongue. So sometimes children really have some very interesting interpretations of what we tell them, and adults too. And then encouraging a lot of questions. Parents don't often spontaneously ask, and the kids don't. So leaving that open, not like this, where you go, do you have any more questions? As you're going out the door, right? Doesn't encourage anybody to ask questions when you do that. Okay, so, modeling and behavioral rehearsal. As psychologists, we should know about this thing, but you were trying to teach your child to use a meter dose inhaler, which is not easy to do, and a lot of professionals don't know how to do it. So you have to shake it, and you have to put it at a certain distance from your mouth unless you're using a spacer. And you actuate it, and then you inhale it, and you hold it in for 10 seconds, and then you breathe it out. Okay, so you do that. You demonstrate that to a family and child. Say, see, here's how you do it, or an exercise, or whatever. And then you say, okay, did you get that? You understand, which is what I call an "Are you an idiot?" question. In other words, is the parent going to say, "Oh no, I'm really stupid. I didn't get that. Could you do it again?" So instead, we say, "Now let's have you practice it and see how it goes for you." And you can get a inhaler that's got inert medication in it, inert substance in it, that old medications, and teach people that way. So don't assume they know, and just because they say they know, they might be embarrassed to tell you that they didn't understand what you were telling them. Okay. Increasing access to health care. Good evidence that the kids who have more severe chronic illnesses that see a subspecialist do better if they see him more often. Consumer-friendly clinical settings, boy, we got to work on that. Our latest report that came in said that parents complained about What would you guess the main things they complained about? Number one was wait time. Yeah, waiting too long to get checked in. Then once they got checked in, they had to wait in the doctor's office, right? And you're sitting there, and then your kid's crying, there's no toys in there. And then when the doctor comes in to examine the kid's not very cooperative, on and on. So that's a big problem. And also parking is at our place, and probably at your place too. If providers would just ask about adherence, which they usually don't, if they make any attempt at all to say, hey, are you having any problems with your medicines? Are they causing you any difficulty? Are you having problems taking it? Is something getting in the way? Are you running out? Do you have enough medicine? All that kind of stuff. They would really help out a lot if they did that. And also simplifying the regimens. So if you can give a drug once a day rather than 2 or 3 times a day, that's better. Or if you can fit a regimen into the family's existing schedule, that's better. That'll help them. And then minimizing negative side effects. So if you know a drug's going to cause stomach aches, say take the drug with food. Take the drug with an antacid. Do something to minimize that side effect. And then behavioral strategies, I really think this first one is very key, which is to have parents monitoring and supervising, even for teenagers. Because I think that what happens with teenagers, they get to be around 13, 14, and the parents abruptly drop off their monitoring and supervision. It's no wonder the teenagers then have the highest rates of non-adherence, right? I think it's because parents pull out of that supervision part too quickly. And then having ways of prompting adherence. There are phone apps. They're setting your phone to beep you to tell you when it's time. You can do a calendar, and I'll show you one of those later on. And then we've done adherence incentives, particularly for younger children, where they're earning points. We use poker chips because they're easy to get to, and they're very tangible, and the child can earn them for doing various regimen requirements. And they could earn some basic privileges, like watching TV or going outside to play, or special things, like saving them up so they can have a friend stay all night on the weekend or see a movie. And those have worked very, very well. And then discipline. Some chronically ill children have difficulty disciplining them. And I think part of that is that they don't want to add more discomfort to the lives of children who have a fair amount of discomfort in their lives. So they try not to discipline. We'll talk more about that later too. We'll talk about contracting. We tend to do that with little older kids, teenagers, where we come up with formal contracts with their parents that we negotiate related to their regimen, what they're willing to do. And then with teenagers, we also really emphasize self-management strategies, setting goals for yourself, monitoring your own behavior, administering consequences to yourself. We do this as adults. I don't know about you, but if I've got a paper to write, and I often do writing on the weekends because you can't get anything done in the office. So Saturday morning, I'll get up and I'll start writing, and I'll tell myself, I'm going to write until, particularly during KU basketball season, I'm going to write until the KU game comes on at such and such time. So I do. I work and work and work, and then my reward is watching that basketball game. Unless we lose, and it ends up being a punishment. But most of the time we win at Kansas. So anyway, we all do that. And then problem solving, kind of like working with the kids on what gets in the way, looking at how you're thinking about things. Taking it out of the realm of this is a conflict between you and mom and dad, or getting back at my parents, or not giving in to my parents. All that, I always say, none of that. This is your body. You've got to take care of yourself. In a few years, you're going to be off to college, and you've got to take care of your diabetes without mom and dad around, or your arthritis, or whatever it is. So let's get it out of that realm. This is me against my parents. This is you. This is your body. What do you want to do? How do you want to take care of yourself? So I think that's a helpful approach. But now here's an example of a monitoring strategy. We have parents in Word, and I'm sure in other programs, you can there's the Calendar Wizard. Are you all familiar with Calendar Wizard? Yeah, we've got family calendars on the fridge. Everybody thinks I'm OCD in my family, but I do 2 months at a time, right? So I know everything that's going on for the next 2 months in my family. And then people write on it, which I hate that. It's all typed, and then they write stuff in. And my wife says, and I said, well, why don't you tell me ahead of time because I sit down and I said, now, do you want me to put stuff on the calendar? And then she didn't tell me. Then she writes something in later. Well, I didn't think about it. I said, okay, anyway, a little personal griping, and she's not going to see this anyway. So she's back at the hotel, or shopping probably. Okay, so this is a kiddo with arthritis. Let's say he's taking naproxen twice a day, and mom and dad, the kid you can give him the medicine, or he takes it and he checks it off, and you can use this for a reward system. So you reward them for so many times they do that. Now, discipline. Let's talk about discipline. You might guess that this cute little girl, Catherine Rapoff, and Lindsay Catherine is about 4 or 5, and I said to Lindsay, and I, by the way, have her permission at the age of 32 to still continue to use this picture. And so I said to Lindsay, would you pretend that you're in timeout and that you're sad? Okay, so this is actually the timeout chair in our old house. You used to sit here right in the corner. Whoops, you sit here right in the corner. And yeah, they went there, for various things. Not very often. They'd go there. And her younger brother would go there, more so than she would, because he had more of a temper. In fact, he was in there one time, and I walked in, and my wife was at work, and Lindsay was sitting on the couch. And I said, Lindsay, why is your brother in timeout? And she said, well, he took my toy away from me. Oh, so I had to put him in timeout. And Nathan's just sitting there going, he's this blonde, blue-eyed little boy. And he's just sitting there like, I guess I have to sit here, So I had to explain to Lindsay that Mommy and Daddy do timeout, come and tell us, and we'll take care of it, But what we do with kids like 4 or 5 years of age, or even up to 10, say, we usually don't go beyond 10. So I'll give you a story. My goddaughter, Jessica, calls me years ago when my godson, Caleb, was on an antibiotic, was prescribed, and he wouldn't take it. And so Caleb calls me Dedo. And Dedo in Macedonian, which is what I am, is grandfather. And so he just has always called me Dedo. And Jessica too. And Jessica calls, says, Dedo, he won't take his medicine. I said, okay, tell me what happens. Okay, so I say to him, it's liquid. I bring it over in the syringe and say, Caleb, it's time for you to take your medicine. Ear infection or something. He says, no, you won't do it. He says, no, does he? Yeah, no. I said, okay, here's what you do. I want you to do exactly what I'm telling you. Exactly. He said, okay. So you say to Caleb, because she wanted to put Caleb on the phone and have me talk him into it. Nah. You don't talk a 4-year-old into stuff like that, right? Like he's going to get on the phone. Dad, I got it. I got to take my medicine. Thanks for explaining it to me. Parents sometimes think silly things. So I said, here's what you say to Caleb. You say, Caleb, it's time to take your medicine. Do you want Mommy to squirt it in, or do you want to squirt it in? Give him a little bit of a choice, right? We took care of the taste thing. It was okay. We masked it with some kind of cherry stuff or whatever. If he doesn't do it, you immediately put him in timeout and say, you didn't do what Mommy said. Like any other thing you ask him to do and he won't do it. He goes to timeout, comes back, and you say, now you're ready to take your medicine. Do you want me to squirt it, or do you want to squirt it yourself? He had 2 instances of twice in a row going to timeout and then saying to Mommy, I want you to squirt it. The 3rd time he said, I want to squirt it. The 4th time he went and got the medicine and brought it to Mommy and said, here, Mommy, you do it. End of story. Now, to me that's like, duh, but it isn't. It isn't. We can't make fun of parents for that. We can't, and particularly if they have a child with a chronic illness. My record is a child with leukemia who wouldn't take her prednisone. Back then we did home visits. And I was there for 4.5 hours. This child went to timeout, came out, said, take your prednisone. No, went back to timeout. 5 minutes later, she's quiet. Ready to take your prednisone? No. back out. So we did that for a good time. Mom and I got to know each other really well. She made me a sandwich, you know, it was over lunch. That child lasted 4 hours, finally took her medicine. One other time, she challenged her mom for about an hour, and then from then on, she took it. She comes back when she was in college. This is the advantage of being somewhere 32 years. Comes back from college, and she came to see me. Dr. Rapoff, do you remember me? And I said, oh, of course. How are you? How's college? Doing really well. She goes, you remember that time I was such a brat? She remembered it. Remember that incident? And she said, oh, I was such a brat. I said, oh, well, honey, a lot of things in life, and you did the best you could, you know. I'm glad you're healthy. So anyway, that's time out, you know, and it's common sense, folks, right? We've got a protocol. I'll show you. So the other thing I do with teenagers is I talk about the way you think about your medical regimen. And what I've done, and these actually are quotes from patients of mine that have either been in studies or I've seen clinically. The first one was from a young African-American young lady who had lupus and was taking prednisone. And some days she took it like she should, other days she took a lot more than she should, and other days she didn't take anything. So she bounced all around, and I said, okay, let's talk about what are your thoughts? She said, this is a quote, I take my medicine depending on how I feel, sometimes more, sometimes less. And I said, okay, what are the possible positive consequences if you follow that course of action or that way of thinking about things? Well, it's okay if you're taking PRN medicine, particularly if you know when you need to take it to match it with your symptoms. But you're not on a PRN regimen, and because of what you're doing, you're failing to achieve therapeutic drug levels for continuous regimens. Now, I explained it to her differently than that, but basically gave her the idea. So this medicine is causing harm or making me feel worse. Possible positive consequences, it may be. Maybe you're avoiding potentially serious side effects. But premature discontinuation of effective treatments, especially when side effects are not serious, temporary, and can be minimized, can be a problem. And that's the kind of thing you have to talk about with your doctor. Or this medicine is not helping. Discuss with the provider. Maybe it'll get modified or other treatments added. That would be a positive consequence. But premature discontinuation, again, could be a problem. I don't really have this disease. Wow. If it's true, then it avoids unnecessary treatments with possible negative side effects. Doctors make mistakes sometimes. Maybe you don't have asthma. I don't know. But if it's false, it heightens the potential for decreased quantity and quality of life. My disease is not that bad. If true, then unnecessary treatments are avoided. If false, it heightens the potential for decreased quantity and quality of life. So going at it like that, of not being judgmental, but just saying, okay, think about what are the positive consequences if you believe this. What are the negative consequences? And you weigh that and see what you think you want to do. We also have that with parents. We have them to notice when their thoughts are helpful or not helpful and try to change these. This actually came out of a program that we're doing online that I'm going to show you later on. So my child often refuses to take medication. Why do I even try? This is a discouraged parent, right? My child does not like to take medicine. I know that medicine is important to his health. By using time out to discipline my child, I'll be helping them to be healthier. So we get them to try to change the way they're thinking. You can't even see this, I know, but let me just tell you about this. This is a barriers measure that is administered to parents in our current program, and I'll just read some of them to you. I just forgot to give my child medication. Pills are too hard for my child to swallow. I'm not sure my child needs medicine. We ran out of medicine. The pharmacy ran out of medicine. That's been happening more and more often. It's kind of scary. It's like gas stations. If you guys had that happen, where you go to a gas station and they don't have any gas? Yeah, it happens at pharmacies too. So my child resists taking injections. So if you look at each one of these things, what you can do is you can tailor the intervention to the unique barriers that the families report to you. So, for example, if they say, I just forget, we talked about that. You know, you can have a calendar, remind you, an app that beeps at you or whatever. if they say my child can't swallow pills, that's a big problem. How many people have heard that from adults too? I can't swallow pills. Yeah. Well, we have a whole protocol for that I'm going to share with you. And you can teach. I talked to a teenager the other day. He said, I can't do it, Dr. If I choke, my throat tightens up. I feel like I'm going to puke. He's describing all this stuff. And I said, well, when you get nervous, you do tighten up your muscles around your throat. And I said, but I'm going to teach you how to do this. I promise you, if you do this program, you're going to learn how to swallow pills. I don't think so. I don't think you're right about that. I said, well, we're going to start out with something a little smallish. I'll tell you about the protocol later, but he'll do it. He'll swallow pills within a couple weeks. Or we ran out of medicines. What do you do about that? Well, hopefully you have a social worker, good social worker that works with you in the clinic that can help the family out, right? Okay. So these were the protocols I was going to go over with you guys. I thought it would be helpful not just to have me yapping all the time, to have you look at these, and people watching online would have these available as a PDF download. See, okay, the first one is from my buddy, Alexander Quittner, and it's called the Prescribed Treatment Plan. Now, this is a fillable form. And one of the difficulties that happens is that sometimes families don't know what they're prescribed, particularly if it's a very complex regimen, and they change over time. And somebody like us who's trying to help people with their adherence need to know what they're on, right? And sometimes when you ask the parents, they say one thing, and when you ask the provider, they say another thing. So if you had this chart like this is in the patient chart in Dr. Quittner's CF team, so that the doctors fill this out, and it's a fillable form, and then everybody gets a copy of it, and everybody knows they're on the same page, right? And it gets updated periodically. I like the idea that it's fillable, so it's very quick. Doctors like really quick things. And they want to make this part of the regular medical record, too, to put that in there. I'm not sure that's been done yet, but I think they're working towards that. So that's the first thing. You got to know what people have been prescribed, and that sometimes it's tricky. So that's that. The second one is steps for written instructions for using an inhaler. And this is adapted from the NIH, who came out with some guidelines again in 1997 on asthma treatment. But as you can see, I think it's a really nice example of very clear instructions with pictures that illustrates how to use an inhaler, okay? And now this one doesn't particularly have a spacer in it, but it's the more difficult version of trying to use it without a spacer. But it gives people a very concrete example of how to do it, and I think it's easier for parents and kids to follow that, along with your modeling and rehearsing of it, okay? This shouldn't take the place of that, but it would be a reminder after you had gone over that with them. You'd give them this handout. Okay, the next thing I mentioned was about pill swallowing. The pill swallowing protocol was originally developed for mentally handicapped children, developmentally disabled children who were having difficulty swallowing pills. And it was published a number of years ago and then adapted by a number of people. The latest version was Alexander Quittner and her group had it for a NIH study they were doing, and they gave me permission to reprint it. But basically, it's a shaping procedure. It basically partly involves teaching a child how to really swallow a pill. So many of them don't put the pill in the back of the throat to begin with, right? So it's hard to swallow like here, right? So you put it like here, in, put it back there, like that. So you teach them proper way to swallow a pill. You want to gun her down with plenty of water. That's part of it, is teaching them how to swallow things, but they can't swallow the pill. So what do you start them out with? What's the smallest thing you can think of? Sprinkles. How many have done this? Yeah. Success? Yeah. Sprinkles. And you talk to the kid I talked to the other day, who's 14. I said, we're going to start with sprinkles. He said, you mean those teeny little things you put on cakes that are flat? And I said, yeah. Do you think you can swallow that? Well, yeah. I said, okay, well, put it back there, practice that technique, and I want you to do that for, what do you want to do it, 4 or 5 days? See how it goes? And then we're going to go to mini M&Ms. And he said, are mini M&Ms, I thought they were bigger than Nerds. I said, no, they're not. Mini M&Ms are smaller than Nerds. So he said, I think I could probably handle those mini M&Ms. I suspect what this kid's going to do is going to try to beat the protocol. He's going to try to speed it up and get right to the prescribed pill. So you do that, and you have instructions in here about other homework and how the parents can help and support the child and be sympathetic and all those kind of things. And then there's also some other strategies like putting in an ice cream or applesauce or pudding, which lets it slide down. Some pills you can grease them up with butter. Some kids don't like that. Or if they've been introduced to olive oil early in life, they might like olive oil on it to slip it down there. But it's a serious thing. My wife had I forgot, this antibiotic. She had a huge pill that got esophagus, and she had a esophageal ulcer. It's really bad stuff. But most of the kids, it isn't the case usually they get it stuck in their esophagus. They really have trouble getting it even past their epiglottis. So if you can get them past that part and feeling like they're going to throw up, it works better. The regimen monitoring form, I showed you one you can do with the calendar function on Word. This is one that we developed that we use a lot with children with arthritis. But parents can fill in anything under regimen requirement that they want, and then this would be a form they put on the fridge, and they can check it off. Child can have more than one medication, as you can see, and how many times a day they can use it. And then token system programs, one that easier one to do than the one we usually do. The one we usually do, particularly the younger children, is the CHIP system program. Now the way I use it is I start the CHIP system with other behaviors. So the children earn poker chips for good behaviors, lose them for negative behaviors, and all their privileges are purchased with the chips. And I mean all their privileges. Unless it's dance lessons that mom and dad have to pay for. They don't have to pay for that. Because parents go, I pay for that. They don't like the idea of restricting that one. So, but this one is a little different, and you can use it for older kids. We've used this for like teenagers in one particular study. And it's very simple. It's this. You got responsibilities to do, and you got privileges each day. If you do your responsibilities, the next day you get your privileges. If you don't, you don't. And if you accumulate enough of doing what you're supposed to do during the week, you can get a bonus. That's what the exchange system is based on. So basically, the exchange is between exchanging doing what you're supposed to do to take care of your illness for privileges. First you work, then you play. All of us have to do that, right? So that's what that program is about, and I'll let you all read that. It's got a nice little summary form on it at the end where parents can keep track. Did my kid earn the basics for the next day? Because you're always earning for the next day, basic privileges. Basic privileges are things like watching TV, playing video games, getting on my phone, cell phone, things like that. And then whether they met the weekly goal or not. And again, you guys, if you start to use some of these protocols and you have some questions for me, feel free to email me. And I won't charge you more than a couple $100. But no, it's free of charge. Okay, so negotiating and contracting. Now this is getting into more complicated, what I will later call tertiary interventions, which would be interventions that that really need to be done by psychologists or social workers, people that are really trained to do this kind of stuff. Because negotiating behavior change with families is a tricky thing. Even trying to hold a family meeting with families that have severe conflicts, as you know, is a real challenge, and often you have to do it in your office and keep everybody quiet and, okay, now wait a minute, he gets to say what he wants to say for, that kind of stuff, where you're holding people back. And then once they get where they can do it in your office, we have them try to do it at a convenient time at home. And, it's basic communication skills, people. It's using iMessages. That's the one thing. I've been married 36 years, and I still use you messages. You messages. You always. You never. How many are you married? How many of you use you messages? Yeah, they're not very helpful, are they? They really get into trouble. Now, my wife's smart enough. She's been with this psychologist for so long. She says, I always do that? I never do that? Well, sometimes you don't do it. So, but if I say, I'm upset that you didn't get this done today, or this happened, it gets to be a different conversation. I don't get a plant thrown. No, she doesn't throw plants. But it's a more effective way of communicating if you own up to what your feelings and thoughts are, not attacking the other person. So that idea. And then also modeling for the children, and also giving them experience of saying, okay, when you bring up a problem, that's not the end of it. Even if you bring it up in an acceptable way, to say, Mom and Dad, I don't like it when you take away my Nintendo because I didn't do my homework. Okay. Now, parents, don't argue about that. That he said it properly. Here's the problem. I'm getting my Nintendo taken away because I don't do my homework. That's my problem, as the kid says. And then we go, okay, what's your solution? Knowing that one of the solutions is not to do your homework. Okay, that's got to be done. But do you have a better idea about homework and when you could do your Nintendo? It's up to you. You got to come up with a solution, right? Teaches kids that you just don't gripe and complain like we do in America, or screw up and then make excuses for ourselves all the time. Nobody wants to admit they did anything wrong. And then monitor the solutions and develop contracts. And I've got an example here of a contract about a young man with celiac, cystic fibrosis, and a contract that we came up between him and his parents. This is an actual example of one that worked out pretty well. We had to tweak it a little bit, but it worked out fairly well. So those are tough, those sessions, but they're really worthwhile once you get families really talking and really listening to each other and really hearing each other. It's kind of a neat transformation to see, and I'm sure some of you have seen that. But it makes it easier to talk about these regimens and who's responsible for what and what you're going to do and what you agree to do and all those kind of things. Okay. Any questions about those? Because this last thing I'm going to get into in a little bit here.
Do you have to encourage parents to keep up with these? The children have their end of the bargain, but parents also have to hold up their end of the bargain to monitor and be organized and make sure these charts and such are filled out.
We review that at the next session. We have sessions with them every week. Often it's the kids who call the parents on it. So, Mom's not doing that. And I'll say, well, Mom, what's going on? Why aren't you doing your part? And we have that kind of discussion. And again, not trying to do that in an accusatory way of, you're a bad person because you didn't do it. There's lots of reasons why people don't hold up their end of the bargain. But try to figure out why the parent isn't doing that. And that does happen. But the kids, that's what I love about working with kids. I came in, even the little ones, where they were supposed to I was talking to a little guy the other day, and about timeout, I said, Mom was saying, well, I've asked him to do this, and he just refused to do it. And I said, well, did you go to timeout? And he goes, she didn't do that. She didn't put me in timeout. Or they say, that's not going to work. I said, why won't it work? Well, because she's going to quit doing it because I'm going to scream and yell, and she's going to get tired of me screaming and yelling. I mean, I've had kids tell me that, and then I tell the parents, I say, is that true? So, yeah, got to call the parents on it, basically.
I feel like that's been particularly an issue for me when you mentioned this earlier, sort of it's important to keep up parental monitoring for teens and adolescents, but I feel like the belief that parents have that their teens have lived with sickle cell their whole life or have lived with diabetes their whole life and should be now more independent and taking care of it makes it difficult to get parents to buy into checking calendars or participating sometimes.
Yeah, they have that expectation, as you said, that the child has lived with this illness all their life. They should be able to take over. And partly, I think part of that, too, is they're tired. They've been having to do this for 13, 14 years. But I tried to explain to them, you can't do that abruptly. You just can't expect the kid to automatically take everything over. It's got to be in steps. And, you do need to work toward being more independent, but it doesn't happen overnight. And some children are more immature than others. I mean, some are ready to do that when they're 11 or 10. Some of them aren't ready to do that until they're 15 or 16. Depends on the kid. And you have to understand your own child and when they might be ready to do that and how to transition over. The other part that I talk to parents about is make sure you have those discussions with your child's CF doctor in this case, because they usually know the child very well too. And if they're in a transition clinic like we have at our place, those issues are being addressed. People are saying, okay, who's doing what right now? Let's talk about how we're going to shift the responsibility more for you to do it, because you're going to be off to college or whatever. And they're addressing those issues directly. That's what I like about transition clinics, which I think they should be in all chronic illnesses, or should be. But the cystic fibrosis community seems to have done a better job of any of them so far in getting those done. And so I think that's where it really needs to come. But it is, yeah, it's frustrating for parents. It's like you're 13, can't you do this yourself? I mean, we have a child that had asthma. Unfortunately, Nathan did really well, but he was 7 or 8 when he got diagnosed, and he's ended up being a fireman, so his asthma doesn't bother him too much. He's got another job now, but he was a fireman for a period of time. But, when he was little and he was having to do treatments and he was complaining about it, and, you can empathize. I empathized with him, and I said, I'm sorry, son. Why did this happen to me? And nobody knows specifically. We do have a little bit of family history on your mom's side. I didn't say it that way. But we got to do it. We got to do these treatments. And I'll sit with you and play a game, or I'll watch a movie with you, but we're going to do it. Of course, he had no chance. His dad is, and his mother's a respiratory therapist. So forget it. You think he was not going to get his asthma treatments? Wasn't going to happen. So. Okay. So, and I'm going to talk about this more later, so tune in later, but I am going to tell you just a little bit about a handout that I'm going to give you that came out of a discussion in, I think it was 2004. So I did a sabbatical in 2004 at Cincinnati Children's Hospital with the Treatment Adherence Center, Denny Droder, and a number of people there, and had a wonderful experience on the sabbatical. But one of the things that happened is that we also were talking about the direction that we were all going with developing CD-ROM, web-based, phone apps, things like that, technology-based interventions for adherence interventions, as a way of getting those disseminated to more people, number one. And in a state like mine, in Kansas, we really would want to get those out to people in the rural areas of Kansas. So Denny's group had a wonderful meeting once a week, big table, all of his staff, all of his postdocs, even some undergraduate or graduate students were there. And it would be about some topic. So they allowed me to take one of the sessions, and the topic was this last handout that you have. What are the essential elements of a CD-ROM or web-based program for enhancing adherence to pediatric medical regimens? All right. So I just came up with some things, and then I threw it open to the group and said, what do you guys think? And here's what they came up with. And, individualize it by the type of disease and developmental level of the patients. You can see under number 2, all the educational things that need to be covered. And they added on this chalkboard online stuff where parents could talk to each other, that kind of thing. And then it would have a behavioral component, simplifying, cueing, monitoring, disincentive for non-adherence, regimen-related thoughts, feedback, electronic monitoring. That's one of the things I think would be wonderful if we could have these electronic monitors if they were cost-effective and patients could have those in the home and then download that data, and in real time you'd get it on the internet. You can look at that kind of data and you can problem solve with the patient. So we've done that in some studies where we were doing home visits, and you'd look at it, you said, I remember one particular kid with asthma, single mom, African-American kid, and we looked at Wednesday from the past week, we were looking at it at their house. I downloaded the data off the MEMS. Oh, no, meter dose inhaler. And I said, what happened on Wednesday, buddy? Looks like you didn't take any of your medicine. You did pretty well. And they both thought, what happened on Wednesday? Oh, I was at my auntie's house. So he stayed, because mom had to work late or something, and he stayed at auntie's house, and he happened to stay all night. Well, he didn't have any medicine over there. So the solution, simple, was let's get another set of medicine for you. You can keep it at your auntie's house. Instead of saying, all right, what happened on Wednesday? What's the deal? Being judgmental. You can use it to problem solve. You can see those gaps and say what happened there. Now, maybe it was a malfunction of the medication monitor, but for the most part, you can problem solve with a person about what happened. So we had that in there. We talked about booster sessions online, parents being able to have the program after they're done doing the intervention so they could refer to it. How responsibility is allocated in the family. And then we talked about the actual technology part. Often some of the programs, and the one I'm going to show you later on today is one for parents, so it's rather didactic. So it's not a very good example of what you do with kids, but the ones you do with kids have to be really flashy and a lot of interaction. They have to go quick. You have to have, content that's broken down into small little segments. So we also have talked about how we probably need to have children do the voiceovers, because when we develop these programs, and we've developed 3 pain management programs for children with chronic pain. We have Headstrong, Gut Strong, as you might imagine, for abdominal pain, and Joint Strong for kids with arthritis. And all 3 times when we did the prototype, we then had kids look at it. And the kids are brutally honest. And one of the kids, I remember, one of my graduate students did the voiceover, and he kind of had a monotone voice. So he was saying, well, arthritis is a chronic illness. And so this young man says, arthritis is a chronic illness. And he goes, where did you get that dweeb? And I said, are you suggesting we may need somebody to do the voiceover? And he goes, I could do it. So this is a kid that was in community, and he had been in a lot of plays and stuff. I said, okay, how much do I have to pay you? I said, how about $10 an hour? He says, how about $15 an hour? I said, all right, $15 an hour. I'll go for that. So I said, I'll call you when I need you to come in the studio and do it. So you know, it was a great idea. And I think that a lot of the kids that listened to that program and heard his voice would be much more interested. And then mixing it up with genders, so having a male do some of it and a female do some of it. And it needs to be flash, and it needs to be interactive, and there needs to be a little quiz where the kids, and we have some of these programs like that, so they click on something and it goes, wrong answer. And, you know, and then you have to go to another, click yes, or whatever it is that was the correct answer. So but there's a lot of IT people. There are people out there that are really creative people. You know, I'm not at all. I don't have a creative bone in my body. What I can do is I can tell those people, this is the content I want. These are the strategies I want to cover in my program. But I want you to tell me how to make it interesting. Should we have music? Should it have interactivity? Should it stop every once in a while and ask them a question? Or have them identify something? Or do something silly? I don't know, whatever. Should we do it on a web-based program? Should it be on a phone app? I think for the teenagers, we're going to be moving to phone apps. That's where they want them. Or is part of it on the web, and then the kids do part of a lesson, and they download a phone app. So if you're doing a pain management program, and you've just gone over on the web-based program relaxation exercises, then you say, okay, here, you can download this relaxation app. And they would have that on their phone, and they could use it anywhere, right? So there's all kinds of creative ways of doing it, and we need people that really, we need IT people, we need, I think, people who are theatrical, you know, kind of the artsy kind of folks, right? And I think we need content people who know adherence and know strategies and all that kind of stuff, like us, to do that kind of thing. And I think we can develop much better programs. And the most interesting thing I've heard so far is actually doing some of these programs and then because the other part of this is disseminating. How do you disseminate it? Let's say you get a validated program. What are you going to do with it? Are you going to sell it to parents? Or are you going to have a professional organization buy the rights to it, to use it? Like, will the Arthritis Foundation buy my program and then give it to parents? Or do I just give it to the Arthritis Foundation, which is fine with me? Or how do we do it? You know, how do we disseminate those things? Do we just put it on YouTube? That's the latest thing I've heard about. You know, you can have your own channel. Who has channels on YouTube? I have one, Michael Rapoff YouTube channel. It's got 3 lectures right now on it. Now, it was done for professionals uploading medical adherence, and there's one on professionalism. And anyway, they're uploaded on there. My daughter thinks I ought to do some fancy dancing and have it on there, but I'm not going to do that.
Do you know if anybody has used participatory approaches to get patients involved in designing some of the aspects of their programs? Have you had opportunities to do that?
Have we had like parents and patients involved in the development of the programs? Absolutely. Absolutely. In fact, what we do with the first prototype, when we go through it and we develop that first prototype, we have the parents, we have like usually a focus group of parents that will watch it, and then we'll say, okay guys, lesson 1, when we talked about arthritis and what is arthritis and how it's treated, what did we miss? What's confusing? What would you guys like to have in there? Same with the kids. If we do in this case, we're doing it for the parents, so we ask them. But if it was kids and parents, we'd say, what do you think we should do? What are we missing? How would you do this differently? Do you think we ought to have some music in here? Was it clear, the demonstrations that we did? So very early on, we have them involved in that. And then once we get that feedback, we also get feedback from professionals too, by the way. So Denny Droder's group, for example, looked at the Adherence Strong, the one I'm going to show you later on. His whole group looked at it. And they gave us a lot of feedback. You should do this, Mike. You should add that. You should take this away. You should, you know. So both professionals and both parents giving you that kind of feedback, I think, is really helpful. Good question.
Do you know if there's any evidence for adding motivational components, such as motivational interviewing, within this sort of program?
You know, I'm not an expert on motivational interviewing, but I would think that motivational interviewing could be incorporated into these kind of interventions, particularly for teenagers that are ambivalent about whether they want to start a treatment or not. That could be a component to it. Of course, when I look at motivational interviewing, it looks to me like since I graduated in 1997, it looks like Rogerian counseling to me, client-centered counseling. So it's funny when people talk about things that look like stuff that I used to know in the past, and they put a new label on it. Yeah, because it has a lot of elements of unconditional positive regard, and you're not trying to make the person convince them of doing anything, and letting them express their reservations. And I suspect you could do it. Concern I have about, there's a lot of people talking about motivational interviewing, and my understanding is that the original version of it that was used often with people with alcohol problems or whatever, was it Miller and somebody else? I can't remember. I'm sorry? Ronick, okay. That they would prefer that people actually get some kind of training in that, and so I would just caution people to not just read a book, but to really get some training and workshop supervision type experience in that, because I really think it's a pretty subtle technique, and it's really hard. I found Rogerian counseling years ago when I was trained in that before I became a behaviorist. I was really into that humanistic stuff, humanistic psychology, and still very interesting to me. But that approach was very different, and you really had to be very disciplined as a therapist not to say things, like not give advice, you know, and to really listen to what people were saying and be empathetic and reflecting back and let people come to their own solutions. And I find that a much tougher way to do therapy. And I suspect motivational interviewing is like that. So how much of that could really translate well into a technology-based intervention? Oh, I don't know. I suspect it might be a little more difficult.